today I thought that I would go through some of the key trends that we analyze. Is that good?
Perfect.
Okay, great. So yeah, go through the kind of context, I suppose, of what kind of health issues that come up in prisons. What's the context that this sits within, because it's so connected to the trends around who's going to prison and imprisonment rates, etc. And then also share a few things around the role of civil society in terms of prison health. So a lot of this data that I'm about to share is documented in our Global Prison Trends report that we publish annually, usually around May. And we publish that with the Thailand Institute of Justice. And it's, I'm not biased, people tell me all the time, it's a really great snapshot type of report, easy to grasp kind of the key trends each year. So keep an eye out for that every year, because we cover different issues, but we always include a chapter on health, including mental health, each edition. So yeah, in 2025, we again documented that there's more people in prison than ever before. So if you look at the growth rates, actually it's slightly lower than kind of the growth in prison, in the world globally, like the world's population rate. But still, that doesn't take away for us the fact that there's more people going to prison year on year globally. And that overcrowding, prison overcrowding, is rife in many places, high income, low income, global south, global north, wherever you look. There is prison overcrowding, except in a few countries. And there's a big issue also around kind of measuring prison overcrowding, both at the national level and at facility level. And so overcrowding fuels obviously human rights abuses, including on the right to health. And we also see a rise in the impacts of organized crime in prisons, and just, yeah, violence and torture and ill treatment being reported at a higher rate in these overcrowded systems. Who are in our prisons? So it's been pretty much stable for the last 20 years in terms of the pre-trial rate, which sits at around a third. But notably in 45 jurisdictions, there's more people sitting in pre-trial waiting for the outcome of their trial than people convicted. And also we see I don't need to tell you this, in Australia, certain ethnicities and Indigenous peoples going to prison at a disproportionate rate, due to all of the social inequalities and racism in the justice systems. And I should mention also that it's not a global trend, but in quite a few countries, there's a larger proportion of older persons. So either from 55 or 65 above, depending on how the country defines older person. And I suppose the health angle to this is that, if you're looking at pre-trial, for example, often facilities don't just have kind of basic healthcare, because the people are supposed to be there really temporarily. So they might, not have the usual or the like full spectrum of health services. Obviously, with older persons, their healthcare needs are much more complex, much more expensive. And this is really an issue in most places where we've looked into it, because they just don't have the palliative care, they don't have the expertise to look after older persons. And when it comes to race and ethnicity, also the health needs are different. And just the systems are usually very for the homogenous kind of, one size fits all. When it comes to gender, the number of women in prison number of women in prison has been rising at a much faster rate than for men, but they're still very much a minority. And at PRI, we do a lot of work around what, is a gender sensitive prison system, and health is really central to that, because if you go into a training with prison officers, and I've done many of them, and you say, like, what do you think about women and their health needs? It's usually like periods or pregnancy. But actually, of course, there's a lot more complex health needs and higher rates of mental illness and substance dependency and trauma that goes beyond their reproductive health rights, for example. For children, so we do include this figure, which is the last figure that has come out by UNICEF, but it comes with many, many caveats around the lack of reliable data, actually, and the lack of records. But of course, children in detention have their own health needs, and often are in conditions and systems that lack the ability to provide pediatric care to the level that those high-risk children need. So I wanted to mention the key drivers of imprisonment, and I guess the try and answer the question, like, why are more and more people going to prison? And drug policies are a big part of this, particularly in Southeast Asia or South Asia and Latin America, but not only. Even here, I went to an event the other day, and there's many women in prison here for non-violent drug-related offences. So currently there are an estimated 2.5 of the 11 million people imprisoned for drug-related offences, and half of those are for possession alone, like possession for personal use. So that's a big driver in some regions. And also this kind of, tough on crime, punitive populism, as we call it, means that you have risk-averse politicians, lawmakers, risk-averse judges, and this, either lack of non-custodial alternatives, or where they do exist, an overuse of them disproportionately, meaning that people who didn't necessarily need to go on electronic monitoring will be monitored, and then breaches end up sending them back to prison or into prison for the first time. And also systemic racism and discrimination, which is very tied up to this criminalization of poverty and status. So people going to prison for criminal offences that very much relate to their financial needs or who they are. And we actually do a lot of work around trying to address criminalisation of poverty and status at the moment. Are there any comments or questions at this point? I'll just pause for a second.
Olivia, one question for you. It just blows my mind that we don't know how many children are incarcerated around the world each year. I recall the UN Global Study on Children Deprived of Liberty estimating 410,000 over the course of a year. And to me, that kind of is indicative of how rubbery our numbers are, which is very frustrating when we're trying to can't even get those basic data.
Yeah. So it is outrageous. I think if I recall correctly, there's a lot of issues around like how states define like criminal justice detention, so deprivation of liberty, of course, for us like human rights lawyers is the best way to understand how many children are in detention. But if you start saying like rehabilitation institutions or special schools, this kind of thing, it gets very murky. And also, it's a very sensitive issue. Governments don't want to report that they've got X number of children in detention because, yeah, all of the international standards and all of the pressure is to lower the numbers. So actually, when UNICEF issued that data, and I went to one of the launch events, and there was like a 1 hour presentation of the caveats before they mentioned the number. And me and a few other NGOs were like, we don't even want to use this number because it looks like we're achieving the decrease that we've all been wanting, but we don't know if there has actually been that decrease because of all the caveats. So, but yeah, it's very indicative of like how kind of, yeah, crime issues and detention issues can still be kept as like a state secret or not completely transparent, which is, in the case of children, really outrageous.
I see Margaret's got her hand up too.
Thanks, Olivia. I'm wondering if there's been an opportunity yet in some of the areas where decriminalisation has occurred to check the impact on prison figures there in those states.
Yeah. Yes. So decriminalisation of certain drug offences, like one example comes to mind because they unfortunately did a U-turn on it just a month ago, is in Thailand. And so there was like a huge amount of advocacy around it, but they basically achieved decriminalisation of possession of certain offences, mainly marijuana. And I can't remember how it was applied, but the female prison population, particularly, where like 90% are held for drug offences, went down quite significantly. But our colleagues who work there on drug policy, I remember last time they were saying, oh, it's creeping up. And so now they've done the U-turn. But there are other studies, and I can definitely look them up and send them to Stuart to share, because a lot the drug policy consortiums that we're part of, they really like document the evidence around crime rates and everything. But it's really complicated business, decriminalizing. I mean, I'm sure you've seen headlines from America, for example, like it is complicated, but it's really the only way forward if you're going to like move to a more kind of public health approach to drug use. Okay, good. So this little infographic comes from our global prison trends, and there's quite a lot in there. But I thought it might just be helpful to lay out some of the key issues. So you can see, yeah, overall, the data that is available, usually issued by the UN, shows that people in prison have much higher rates of HIV. They also have higher rates of premature deaths than in the community. Also hepatitis, TB, wherever there is the numbers, it's across the board worse health outcomes than for people in prison. And I think one issue that we have been increasingly trying to draw attention to is around so-called natural cause deaths in prison. Because in many investigations where they are carried out, there'll be attribution actually to inadequate healthcare. So say a prisoner dies of cancer, investigations often show that they probably could have lived longer or actually could have been cured, but just for the lack of kind of timely interventions. In countries where we work, which is usually in low income kind of punitive environments like Central Asia, North Africa, the Middle East, etc., and East Africa, kind of healthcare problems are from the conditions, and then there's just a lack of healthcare, so everything kind of like spirals, and there is a higher rate of deaths than in most communities. So suicide in prison is one of the spotlight chapters that we included in our 2025 report. And yeah, the UNODC has reported that more than 1 in 10 deaths in prison are suicides, which is 3 times higher than the global suicide rate reported in 2023. But there are regional differences, and in Europe and the Americas, that's where the highest rates of prison suicides are reported, which might be an issue around data. But we also include a summary of a review done by academics in 2024 of 82 jurisdictions, which identified some really interesting things. So, for example, in many high-income countries in Europe, where overcrowding levels were really low, prison suicide rates were actually higher, despite the fact that they had better access to mental health care. And this kind of correlation indicated or suggests perhaps that there was a higher prevalence among people who were held in single cells because of all the loneliness and solitary and all of that. Whereas the countries with higher prison occupancy rates showed lower suicide figures, perhaps due to the shared cells and more contact and so on. Yeah, so it's a very interesting study. If you're interested in it, I can also share the link to that. And another thing to mention is that the gendered impact is really stark when we're talking about suicide in prisons. So that same study found that women in prison are more than 10 times likely to die by suicide than women in the general population. Harm reduction in prisons, I think linked to the number of people who have used or start to use drugs in prison. I mean, the punitive drug policies have led to overrepresentation of people who use drugs in prison, but the access to harm reduction services globally is really, really dismal. So an estimated 1/3 to half of people in prison have a history of drug use, and all of the kind of high-risk behaviours that come with that in closed settings mean that harm reduction services should be a given. But Harm Reduction International, which is the kind of international NGO that maps all of this stuff, found that only 11 countries have an NSP in at least one prison, which is 12% of the 93 countries that provide such programs to people outside of prison. So yeah, the situation there is worsening as budget cuts happen, and it can often be one of the first things that the prisons that did have harm reduction services have cut. So Harm Reduction International, they release data every year on this topic, which is very comprehensive and yeah, really helpful for lobbying and advocacy on this issue. Talking about lobbying and advocacy, yeah, I just thought to recall, so there are many international standards on prison health. We have the UN Nelson Mandela rules, which are the standard minimum rules for the treatment of prisoners. And they're from 1955, but they were revised in 2015, and 5 areas were revised, including healthcare. And so they kind of provide the minimum blueprint for prison administrations. And WHO and many healthcare experts were involved in redrafting those rules. The UN Bangkok rules on women, they supplement the Nelson Mandela rules, so they provide a gender lens to minimum standards of detention. And then we have all the WHO standards, also the WMA standards. like huge amount of jurisprudence, particularly from the European Court on Human Rights and the Inter-American Commission. We have many best practice databases. We have, a lot of evidence base to implement good healthcare in prison, but we unfortunately don't see implementation of these everywhere, or perhaps in full anywhere, I could be as bold to say. So thinking about the key kind of, or trying to summarize, I suppose, some of the key barriers to seeing implementation of all these standards, we always mention these three. So healthcare in prisons, especially in countries in the global south and low income areas, but perhaps also extending to more middle income areas, is that healthcare is not really seen as a priority of politicians in prisons. Prisons in general are constantly fighting for resources, etc. And so this kind of punitive, let's say punitive politics over public health, unless you have really good, bold leadership, tends to be the norm. Then this is connected to, but perhaps also exacerbated by the fact that it's not really a priority career path for many in the medical profession. Prisons are often in like faraway places, especially where there's overcrowding. The security and violence, going into those prisons is real, and it can be a really fulfilling, enjoyable job, but you need to have everything that comes along with it, including proper pay, and often healthcare remains under the Ministry of Justice or the Ministry of Interior, and they just don't have the kind of finances and resources and so on to give to these people. Also, many of the professionals that we see providing healthcare in prisons are not trained specifically on the needs of prison populations. So this contributes to gaps in continuity of care and specialized treatment that is needed, particularly around mental health. So we have some pretty stark examples where there will be like one psychologist for 30,000 prisoners, this kind of thing, where there's just, there's just nothing really. So a lot of systems try to rely on like peer-to-peer like support and so on, but it's just not adequate. And this third point, as I mentioned, this lack of integration with national health systems. So the WHO has long recommended that ministries of health deal with prison health, and that is the case in more and more countries. So we were involved with the transferal in Kazakhstan, for example, which took 5 years. And apparently there's still kind of teething problems. But that approach is really in response to the fact that otherwise you have kind of fragmented care, you have poor data systems, and just this lack of kind of a holistic strategy. And during COVID, there were many examples where the integration helped protect the prison population because they could access all of the equipment needed that, say, hospitals could in the same way. They didn't have to kind of have their own battle. They were immediately included in those plans and responses. I'll pause there again for any thoughts, or also I'd be interested to hear from you how you see this in your work as well.
Olivia, I'll go first then if nobody else will. Look, I'm really interested in this governance issue, the integration with national health systems. And, my personal sense is that it's definitely the right way to go, but it's not without challenges. And one of the ones that I'm seeing more and more as I talk to prison health systems is that when health is delivered by corrections, they're seen as kind of part of the inner circle. And one of the potential risks of transitioning to having a Ministry of Health delivering healthcare is they become like a service provider in somebody else's patch. And so that to me doesn't seem like a reason not to do that, but it seems to be a reminder of the importance of governance and shared power, and sharing power in those settings it seems to be quite a fraught thing. I don't know if you've got any reflections on that.
Yeah, I think the shared or the strategic coordinated approach is the key, because as you say, otherwise it's too fragmented again. But I think it's kind of like anything. We also talk about it with relation to like disaster risk response and mitigation. Like if you're not, because typically prisons, they're just left out, like, even council plans and so on, they wouldn't think, okay, what's going to happen when there's an earthquake to the people in prison? And it's a little bit the same. So if you're talking about like health emergencies, I think there's a really strong case for that joined up, or like that kind of integrated approach. But indeed, I think it's not the magic bullet, basically. I mean, I think in terms of budgets, in Kazakhstan, for example, they are better off because the health system has more money. But there also needs to be buy-in from the health ministry that they want to, spend their resources on the prisons as well. So I think you're right that it can also become a bit of an advocacy, like internal battle and so on. But there's a lot, there's actually a whole publication by WHO documenting experiences, and we added a piece on Kazakhstan. So it'd be worth looking into that. But what's the situation in Australia? Or I guess it differs state by state.
Yeah, it does. And, without identifying states, there's at least one that I think would like to transition from the Ministry of Justice to the Ministry of Health. But, ironically, it is the cost that's one of the barriers, that there's a recognition that for health to take it on, that comes with the standards that a Ministry of Health would have. So, which is obviously appropriate, but kind of ironic.
Yeah.
I think most Australian states and territories now have the Ministry of Health running things, or at least subcontracting things, but there's a couple of weird in between arrangements too.
Okay. And what about harm reduction services? Does anyone have experience?
And if anybody else wants to chime in, please feel free. I think, we have jurisdictions where we don't have condoms yet. We have no jurisdictions with the needle exchange.
Okay.
So I think we've got a long way to go. At the end of this, I'll share our next webinar actually is talking about needle exchange in the Australian prison
Okay.
context.
Oh,
So
great. Okay.
yeah.
I just have to mention as well, trying to get in-reach services for Indigenous population. That's a whole extra complexity to try and have support and advocacy, because as always, security trumps health no matter what part, but it's particularly problematic to then try and allow for particular needs.
Yeah.
And Lindsay.
Yeah, thanks, Olivia. I just have a really quick question around, I love the reports and cite them often because there's such little information in this space, so that's really helpful. I'm just wondering, from your experience, like if you could comment on what prison healthcare is like in some of the lower income countries. I mean, we all have Australia in mind and other developed countries, and it's not good, but I'm not sure if you've been to many prisons or done any direct data collection or have any insights to what that really looks like, because I would imagine it's even worse.
Yeah.
Or non-existent.
Yeah, I mean, I think every year in Global Prison Trends, we start with this really depressing paragraph, and sometimes we're like, should we balance this out? But on a whole, it's really abysmal in a lot of the places where we work. So if I take, well, I don't want to mention countries, but because we try not to pinpoint, point our finger, but if you take like your regular prison system, for example, in East Africa, there would be like a nurse or somebody that would do like a little assessment when you enter prison. But anything requiring like complex care, including around mental health, would just be like part. And it's usually civil society or ICRC or family that provides the medicines that are needed. And yeah, I mean, I've been into many medical clinics and prisons in different regions. And you can just see the lack of equipment, the lack of like things available, you know, unless the ICRC has invested. So like in the Philippines, for example, in one of the big prisons there is this huge new building that they built, and they had like a proper pharmacy and everything. It was really impressive, but that's from international development money. And now that Mr. Trump has decided to pull all funding and the UN is in crisis, I think like healthcare will only get worse in those places. And that's, yeah, it's pretty dire. And as I mentioned, the mortality rates kind of show it as well. I think when it comes to like mental health care, there's a big barrier in terms of the stigma in a lot of regions where anybody that's kind of needing really psychiatric care, specialized care, they are a bit abandoned and put into solitary confinement, or put in with other people who they believe are also needing that care. There's just no resources. But yeah, I mean, we do quite a lot of training for prison staff actually on mental health because there are no psychologists. So we try and like reduce the stigma and get them to understand like some of the kind of more common disorders, like even depression, and you know, so that they can at least be sensitive, even though they can't actually like provide the medical care. But it's, yeah, the mental health, I'll speak about it a bit more in a second, but that's, I think, probably I'd say the biggest gap in low income countries to do with lack of expertise, stigma, and just the great needs from people who have experienced like terrible trauma and so on.
Thanks so much. Maybe in number 4 is underdeveloped health systems in general.
Yeah, you're right.
In some of these countries. Yeah. Thanks. That's really, really informative and bleak.
Yeah. I'm all about bleakness. I'm sorry. Yeah, so the role of civil society. I put this picture up. This is Elizabeth Fry, who was one of the first penal reformers. And I put her up because actually she was she first came involved in this penal reform work in the early 19th century when she was really shocked at the unsanitary conditions that women faced at Newgate Prison in England. And at the time, she opposed solitary confinement, which was actually happening back then and obviously a practice still used. And she argued rightly that it was bad for the health and mental sanity of the people in prison. Now, of course, we have a huge wealth of evidence around solitary confinement proving that, and we also have because of that, limitations set down in the Nelson Mandela rules and the Bangkok rules on solitary confinement. So I think since then, civil society has obviously developed greatly. And when we're looking at the type of work that organizations like PRI do, we're obviously international, but there's many NGOs working all over, either at national level or just providing like pockets of support. These are the kinds of things, I suppose, that we're up to. So advocacy at the national and international level, fighting for prisons to remain on the agenda, and things like the Mandela rules would never have, you know, come to life if NGOs were not there reminding governments and the UN agencies. Even we were saying before, like there needs to be even lobbying to the WHO and UN agencies to keep prisons on their radar and as a priority. Lots of NGOs hold facilities and also governments to account around rights being violated. Many have taken, for example, countries to the European Court of Human Rights in Europe, for example, and that comes along with monitoring, either independent monitoring with specific mandates or just the type of work that we do, which is less formal monitoring, but kind of needs-based assessments and technical support to governments. And filling the gaps is what I mentioned before, like actually providing medicines and so on. I'll give a couple of examples in a second. And really important, this kind of holistic support. So, for example, we link up people who have been completely kind of lost touch with their family, and kind of the impact that has on their mental health when they're like reunited is just huge. And post-release support, where the system in many countries that we work, for example, that once you're released from prison, that's just the end of it. And so NGOs are often there at the prison gates, supporting and helping to make sure that people are safe. And when it comes to healthcare, have a prescription, for example, and so on. So a couple of examples and kind of principles, I suppose, that we use in working in really, really difficult contexts. So currently we work in quite a few conflict zones, including Yemen and Sudan, for example. So thinking about how we do that and noting that we are not a healthcare provider, the first thing we do is mobilize local actors, and this is usually civil society organizations, because they are known, they're trusted, they can provide like the local context. And really importantly, in Sudan, for example, they can get to places where we just can't reach because of logistical issues. So in Sudan, where there's like a complete devastation of all public infrastructure, many of the prisons were actually destroyed or emptied, and people are just constantly on the move. So the program that we developed before the war had to be completely completely adjusted. And so instead of doing our like big legal aid network, we decided that there was like a big need for health and like basic medicines and also food. So we created this network of civil society organizations and delivered like essential humanitarian and medical support in 2 prisons and also in some of the IDP camps. And when a cholera outbreak occurred, it meant that we were able to respond really quickly. And I think it's not an understatement to say that like hundreds of lives were saved because we managed to get everything organized really quickly. So we've established 10 prison clinics, and also, we're working with now 20 prisons across the country. And it's a constant challenge, but we continue to just find more and more local actors in like far-flung places and support them with delivering the work that we hope will at least provide the basic care to people in the country, prisons. The second kind of approach that we take particularly where there's like low resources and fragility, is to work with communities. So not just look at the prison like in silo. So for example, in northern Uganda, where we work with refugee hosting communities, there's like a lot of refugees in the north. The people coming into contact with the law, getting arrested for all sorts of different reasons. They have, been displaced. They've, their families are broken. They've often suffered trauma. And so again, they need like legal aid, but that's not all. They need like psychosocial services. They need like, crisis mental health services. And so we've worked also with community leaders to foster this kind of like restorative justice circles, for example, and provide mental health counselling through service providers that are in the area. So this kind of community link is really important, because otherwise you end up also just providing one piece of the picture of the needs, which are really great. And lastly, in that example, I've already kind of, I suppose, nodded to this, is that the mental health issues, particularly in these really low income, fragile states, is just a really cross-cutting issue. And so we've looked to see how we can try and mitigate, or at least try and help the people really in need. So in Central African Republic, for example, we were working with the prison system and the government there and the UN peacekeepers, and we came up with this kind of model to have a more peer-led, so like civil society actors would be trained on certain things, and then they could go into all of these prisons where there's like local dialects and so on, and deliver basic training on mental well-being and also health and hygiene, just really basic things like using soap and this and these kinds of things. So yeah, we have to be quite creative and agile in these contexts, but it's, I think it's a kind of creative way of addressing some of the mental health needs where there's just no resources at all on the government side. And that's the end of my presentation.
Thank you, Olivia. That's it's an extraordinary body of work, and what PRI does is so important. And I think you're seeing lots of things that most of us don't get to see. So it's really important that you share all of that. I'm sure there are questions, so I'll hand over to others who might want to ask something. Please turn on your video if you can. We'd love to see your faces. Louise, yep.
Yeah, thanks, Olivia. Always great to hear the work that PRI is doing. I'm just wondering, you mentioned a bit about the impact of the USAID funding cuts, and I'm wondering if you could speak a bit more about what you're seeing globally about the impacts of that.
Mm-hmm. Bleak. No, it's very serious. I think it will be long lasting because, programs, I mean, the US were a big financial and like moral supporter around HIV/AIDS, around sexual and reproductive rights. And so they gave, for example, huge amounts to UNODC. Like if we just look at the kind of institutional level, not even NGO level, I think they funded I think I heard like a third of UNODC, and they have a big, prison program. And for UNAIDS, huge. And so, yeah, we can just only imagine what's happening out there, and many smaller civil society organizations have just had to close doors for them. I mean, the week that it happened, I just heard from so many people who had basically lost their job. But even the bigger ones like Terre des Hommes and so on, like, yeah, they also had funding, and it's kind of, their operations will be cut. And so when that happens, we were lucky in that we didn't have any US funding at the time, but we will definitely feel the there's just less money to go around. But it just means that the organizations have to make really tough decisions. And you can already see that at the institutional level, where they're having to say, okay, we're going to prioritize based on these like criteria. And it's just devastating. Like, because they're like, these are the most crisis. And it's like, yes, the most crisis now, but all of the others are in crisis too. So in terms of like, just humans out there, the harm is just really devastating. And I think this comes not just with the US cuts. The Dutch, they've also moved to a right government, and they're having a massive development, civil society, human rights cut. The UK have decided to put all of their money into defence. France, I mean, it's across the board. So the picture for civil society, development agencies, UN, everything is it's just a massive concern. I think it's like consuming everyone at the moment, but you just carry on and just hope that some high income individuals will try and fill the gap somewhat, but it's a bit slow. They're a bit slow coming forward, but now would be the time. So it's a worry. And I think prisons are never popular, they're never funded. We're already fighting, for justice systems to be invested in. So amid all of that and all the kind of competition for issues, it's really worrying.
We should see if we can find a silver lining to end this with. What do you reckon?
Sorry.
Lindsay.
Full disclosure, this is not the silver lining. It's more of a logistical question around how you collect the data for the reports that you do every year. Is it survey-based? Do you ever get any pushback? What's that experience like? I just submitted a commentary around global prison health data collection and essentially how it doesn't really exist. And it's very challenging.
Yeah, exactly. It's really challenging. So I think that's why I like to describe it as a bit of a snapshot, because it's just not a comprehensive, it's not kind of comprehensive and like academic level, I guess, so what we do is we have access to quite a lot of data just through our relationships with the authorities. So they often send us stuff on a monthly basis in the countries that we work. And then on top of that, we get information from like everything that's out there published in the year. So we track it all year. And then we also try and verify with all of our local partners that we have. So we have just a massive global network of people that we know that work in this area. So we also go to them on certain issues. So it's a bit of a mixed bag, to be honest, how we get it all. We do some exercises where we dig really deep. So when we, for example, when we did something around prison budgets, we requested, but we also went kind of deep into budget discussions in parliaments and things to try and get the data. But it's often caveated with this is not completely comparative and all of those things, because I think every year in the kind of launch and the intro, we have to say this is just the lack of data is really reflective of the whole problem of prison. It's not transparent. Like, why doesn't every government have a website that compares their prison population spending? I mean, it should just be like other areas, other public areas, but it's not.
Well, it is very impressive how much data you do collect and on such a consistent basis.
Thank you.
But amen to that, Olivia. Couldn't agree more. Margaret, you got your hand up.
you. Thanks, Olivia. That presentation was bleak, and I'm from the lived and living experience community, so it's also incredibly, awfully validating in terms of the experience. I wonder, and this is not my Pollyanna bid at 5 minutes to go, but I wonder if, given the lack of power to do anything about decisions by governments like the US and others in terms of where funding cuts are. And linked to your comment around the empowerment in education and learning from peer communities in areas where, traditionally service providers may have found it hard to get traction, or there may not be any service providers. Is there therefore an opportunity opening up to invest more directly and deliberately into empowering kind of peer communities, which then has the ongoing, well, I think has, I say this with no research backing me up whatsoever, Olivia, because I'm not a researcher, has the ongoing impact into the community of community development and public health benefit as well.
Yeah, I totally agree with you. And I think slightly different angle, but our approach has always been to not do what, and ICRC are like excellent at what they do. So this isn't a critique of them, but they also have a lot more money than us, but not to go in and be like, we're the expats who, have this expertise, but more build the capacity and give financial capacity to local civil society organizations. So we do deliver work ourselves sometimes, but that's usually when we have local staff there. But a lot of it is like building civil society networks or building the capacity of the centralized like prison system so that they can actually, carry this on, because we are probably like every other NGO nearly in the world, we're funded on a project base. And so we're always like, how do we keep, how do we make sure that this can carry on to some degree after? So yeah, this whole like community-led interventions and services is, I agree with you. It's, I think, one silver lining maybe, Stuart, of all of these funding cuts is that everybody's having to like rethink like how we work, and were we all just kind of like fatigued and just carrying on with the same model. It's just a little bit of a tough one being like ripped, the plaster's being ripped off, but there is quite a lot of commentary out there about that and about things having perhaps been a bit broken, and maybe this is an opportunity where we're forced into looking at different models.